bursitis, which again is due to inflammation of bursas. Again, in the shoulder region, we have an acromion bursa, which just lies just under the acromion there, and it also extends into the deltoid. So it really is a bursa that is in two parts. And that subacromion bursa is the one that is prone to bursitis. Both these parts, which are subacromion, and subdeltoid, deltoid. So both of these parts will have bursitis from the irritation, either the acromion or indeed at the deltoid muscle, which again I will cover when I do all the muscles of the forearm, and indeed the biceps and triceps. So we'll have a bursitis. There is also frozen shoulder, which usually affects the elderly. There are also a lot of rheumatology, shall I say inflammatory processes, rheumatological inflammatory processes that lead to shoulder pain. Another is a dislocation. I haven't done this in order of importance or in order of how common things are. Dislocation, mostly of the glenohumeral. Had I done? No, I hadn't. Glenohumeral joint, which is obviously a very shallow ball and socket because it's shallow ball and socket. So it is quite prone to dislocation, and usually the most common dislocation is the anterior displacement of the head of the humerus. So anterior displacement of the head of the humerus, which usually can arise from trauma, blunt force trauma to the posterior aspect of the upper limb, or indeed pulling or falling, really. So, but mostly it's usually the anterior displacement of the humeral head. Another will be fractures. And the most common fractures that will occur are the clavicular fractures, which I've mentioned, particularly in children, even people up to the ages of 11 to 17 or 18, and it can be due to a fall or contact sports. Other fractures will be the head of the humerus, the most common ones. And when I say most common, no, not head of the humerus, actually that is wrong, proximal humerus. And when I say most common, I don't mean that they frequently occur, it's just that they are the ones in the upper limb, in the shoulder, the aspect that I've discussed so far, without the addition of the radius of the forearm, where fractures are most likely to occur. So I'm quickly going to I'll discuss rheumatological pathologies when I cover the rheumatology aspects of module 2. I've briefly touched on dislocation, so perhaps it's best to just quickly, again, others are rotator cuff, either a tear or partial tear, or inflammation, leading to impingement. And again, the impingement really is due to the shoulder having very little room for any inflammatory process to occur. For example, the rotator cuff muscles lie, the supraspinatus will lie there, the subscapularis and teres minor and infraspinatus will lie there, so that they encircle the head of the humerus. And when we look, even if we were just to look on the surfaces themselves, there isn't that much room for maneuverability or to accommodate for any inflammatory processes, particularly where obviously inflammation causes swelling. So there isn't a lot of room to accommodate for any swelling, which really means that if there is any swelling, that movement of the joint is restricted severely, leading to impingement and further pain. Because if we were to remember, the shoulder is highly mobile, and that mobility is allowed for by the number of muscles that it has and tendons that it has. So if they were to become inflamed, they will take up a lot of room and restrict movement. I have briefly discussed bursitis. I'll quickly touch on frozen shoulder so that I can then wrap it out. So frozen shoulder occurs in 3 stages. Again, there is the initial phase, which is called the freezing. In the freezing stage, there is a lot of pain and stiffness of the joint. Again, frozen shoulder, is called adhesive capsulitis. And if we can remember, I mentioned that joints, I'm just going to ever so quickly, have a capsule. And so we're talking about the inflammation in the capsule there, reducing the flexibility of that joint. So we'll have pain and stiffness due to a lot of inflammation. The causes of adhesive capsulitis are known. So it is thought to be an idiopathic condition. Idiopathic causes. There is, considerations that it could be autoimmune. So it could have some autoimmune aspects. So its initial stages have a lot of pain and stiffness. And this can last for weeks to as long as 9 months really. And then the second stage is called the frozen stage. And in the frozen stage, pain has reduced or resolved. So pain resolves. However, the stiffness continues. And again, this can last some 9 months. And then the final phase of adhesive capsulitis is the thawing phase, where the stiffness also resolves. And obviously when we say resolve, we don't mean that it just happens overnight. So this can last some, 26 months while this is all happening. And again, usually the cause is unknown, and really the management will be to manage the symptoms, manage pain with analgesia and anti-inflammatories. And analgesia. And then also restore mobility, as in preserve, try and preserve or restore mobility with physiotherapy and rehab. Usually once the stiffness has resolved, people can also have manipulation under anesthetic, where the surgeon will go, will inject an anesthetic, and then move the joints in order to free the ligaments and the capsule really, and the tendons, just to try and introduce some mobility. It does work for some people, but it does have some good results. So this is how you would manage a frozen shoulder. So the most important thing really is to introduce mobility. So in terms of tendon ruptures and sprains, including any inflammation such as the frozen shoulder, problems that occur obviously are the increasing inflammation, and activation of fibroblasts, which then introduce collagen, which then increase stiffness or reduce range of mobility. So while inflammation reduces space, so we're talking about strains, sprains, and tendonitis, any things which cause inflammation. So while inflammation will reduce space, its healing also has problems in the sense that it introduces collagen, which then increases stiffness and reduces range of movements. So really most of shoulder pathologies, the management has to involve rehab to restore function, and that rehab includes a lot of physio to increase mobility. So the shoulder is a highly mobile joint, and the focus really is always to try and restore and increase that mobility to what it was, as people are recovering from those inflammatory processes. And also, one of the most important things to remember really is that even degenerative processes do cause inflammation, and again do cause stiffness. So really, exercising, even a bit of exercise on their own, as in a patient doing it on their own, even without the introduction of the physiotherapy, does help to restore that range of movement and to preserve function of the joint itself. So in terms of dislocation, so now I'll move on to dislocation. These were just a brief talk on rheumatological inflammatory processes. So in terms of dislocation, the most common dislocation, it is the glenohumeral joints, because it's a shallow joint. So usually with a dislocation, it can be done under local anesthesia, or general, really. And the main important thing is to reduce that dislocation. So to fix it, really, and then rest it with a sling, usually, while there is some inflammation. But then again, rest, and obviously analgesia and some ice to reduce inflammation. And then after a bit of resting, really, depending on how severe and serious the dislocation and the trauma or whatever the underlying pathology is, just a few weeks, really, 2 to 3 weeks perhaps, but just really a few weeks. Then again, the physio to restore function must be introduced. If it's a very large dislocation, it can also be done under anesthesia, or it can be, an open reduction if need be. But usually it's not that common to have an open reduction for a dislocation. But indeed, it is possible that, you can have a dislocation where the joint perhaps ends up there in terms of a massive trauma, and obviously trying to reduce that back will be near impossible, especially if there is a lot of pain, swelling. So it might be better to just open up the joint and then reduce it, and perhaps also introduce some fixations with screws if need be. But then again, the point really is to restore function with the shoulder joints. And then in terms of fractures, the most common fractures that occur are the clavicular, which I've mentioned so many times. So I'm not really going to talk about them as much. Obviously, there are complications at the bleeding because of the subclavian arteries, and indeed also because, the loss of, damage to nerves of the brachial plexus. So the most important, is again to manage that the fracture. Again, is with a sling, resting it, similarly to a dislocation, but obviously this is a fracture. So it has to be the reduction of a fracture, and then the resting of the joint in order to allow for bone healing to occur. Obviously then managing symptoms such as pain, and then once bone repair has undertaken, bone repair again occurs in stages. I'll cover that later. Then restore function of the joints, because while the clavicle is there, and we can indeed think of the sternoclavicular joint and the acromioclavicular joint, it usually breaks at the medial aspect. And although we think of a clavicle as being fixed, it does play a role in terms of the movement of the glenohumeral joint, in terms of the scapula itself, because it does articulate with the scapula. So once once the fracture is healed, there is a need to have physiotherapy and restore the function of that glenohumeral head, and indeed the function of the scapulothoracic joint, which is at the back, which allows us obviously to protract, retract the scapula and lift our arms and objects, and indeed the objects. So other fractures are the proximal humerus, and the proximal humerus has, when we talk of proximal humerus fractures, we must discuss their classification. I don't know why I've done that. Their classification. And their classification can either be based on the near classification, so this is the head of the humerus, the anatomic neck, the lesser tubercle, the intertubercular fossa, or intertubercular groove, and indeed the greater tubercle, which I'll just write as a GT, and then the surgical, so that's it's obviously, it's not really a line, it's an imaginary line, which is our surgical neck. So the near classification system, which is near, divides the proximal humerus into 1, 2, 3, and 4 divisions, and then it will grade the fracture based on it will then grade the fracture based on its position. For example, a fracture to the anatomic neck there would be called a type 1 fracture. And again, when we say, when I say it's based on, it divides it into sections, again, that division into sections also leads to fragments, the number of fragments or separate pieces, separations of the bone that will end up with. For example, a type 1 fracture occurs at the neck of the anatomic neck of the humerus, and leads us to have the heart on its own, and we only have one fragment which is separated from the entire humerus, whereas a lesser, say a fracture to the lesser tubercle will, it will be there. However, when that happens, we then have a lesser tubercle separated, we'll have a head on its own, and we'll have the type 2. So this leads us to having two separate fragments, whereas type 2 near fracture leads to 3 separate fragments, as in, we'll have 1, 2, and then 3. So type 3 again leads to 4, and then type 4 has more because it will have 1, 2, 3, all the segments breaking. And again, the management is based on where the fracture is. If it's a fracture that can just be reduced and then stabilized with pins or even the external fixations, that will be done under surgery. But if it's a simple fracture, it can be immobilized with a cast. But obviously, we then also need to look at the complications of fractures. For example, a fracture to the lesser tubercle, is at a risk of damaging the cruciate artery, which lies in the intertubercle fossa, and it is also at a risk of damaging the median nerve. So we have to take all of this into consideration as the complications that can arise from a fracture. And other complications that can arise from a fracture will be a malunion, where even immobilizing a fracture, in hoping that the bone will then heal, the bone heals, but then there is malunion instead of it being a nice and continuation of the bone. Say this was the site of the fracture, there is malunion, where perhaps we'll end up with that, which really means that that area is prone to more fractures or arthritis and degeneration due to its malunion, really. Other complications that can arise from a fracture will be non-union. Again, non-union is really, self-descriptive. The bones do not unite and they do not heal to form a continuous bone. There can be necrosis of the bone, especially in terms of if an artery is disturbed during trauma or indeed during the treatment phase. I mean, although this, the likelihood of all of this happening, particularly in terms of avascular necrosis, are very little, we do have to take that into consideration anywhere. Other complications can be compartment syndrome, especially for a fracture that is at the proximal aspect, say, of the shaft, where if you were to look at the humerus, it doesn't really have much room to allow for any inflammation. So it can be perhaps a cast that is too tight, or indeed just a lot of inflammation, causing what we call compartment syndrome, which really is a medical emergency and just requires immediate treatment before that arm actually dies. And the treatment usually really is to say if there is is to relieve the pressure, because this is just increase in pressure. So if the pressure is due to a cast, remove the cast. If the pressure is just due to whatever the immobilizer that's being used, it has to be removed. If the pressure is due to just an inflammatory process, an incision can be made to open up that